Alright, this is going to be airway management and ventilation part 3. And in this one we're going to talk about alternate airways. Esophageal-tracheal combitube used as an alternate airway. It is a dual lumen airway. Two tubes are laminated together. Ventilation port for each one of the airways. Tracheal and esophageal tubes. The tracheal tube has an open distal end. If the combitube is placed in the trachea, it acts as an endotracheal tube. Esophageal tube has a closed distal end with fenestrations, which means holes. If the combitube is placed in the esophagus, trachea ventilated through fenestrations. Now, no matter where we place this, if this end of this distal tube actually goes into the trachea, that's great. If it goes down into the esophagus, that's okay too. Whenever this cuff is blowed up and this cuff is blowed up, the only area that's open is these holes in this tube, which with these two closed airways, the only path that's left open is into the trachea. Inflatable cuffs. The distal cuff, if the combitube is in the trachea, acts as distal cuff on the endotracheal tube. If the combitube is in the esophagus, it seals off the esophagus. Pharyngeal cuff seals off the oropharynx, which is this. Ventilation is provided through a BVM. Sizes 37 French. Patients between 4 and 5.5 feet tall. And 41 French is for patients between 6 and 7 feet tall. There are some advantages and disadvantages to this device. Advantages are that it's a pretty good rescue device, rapid and easy insertion, blind technique. Patient can be ventilated regardless of the placement. Diminishes gastric distension and regurgitation. Can be used in trauma patients. And you can suction the stomach if the combitube is placed in the esophagus. Disadvantages. Tracheal suctioning impossible if the tube is in the esophagus. Endotracheal intubation difficult with the combitube in place. Cannot be used in a conscious patient or if they have an intact gag reflex. Trauma secondary to the actual cuff inflation. Sometimes we get some trauma in the esophagus or the upper tracheal area, depending on where its location. Trachea not completely isolated. Cannot be used in pediatric patients or those with esophageal disease or if they've had any type of caustic ingestion. And there's a size chart. If they're lower than 4 feet tall or more than 7 feet tall, then that kind of excludes them from the combitube. Pharyngeal-tracheal lumen airway, or PTL airway. Like the combitube, is a two-tube system. The tubes are separated. A long tube is designed to enter in the esophagus or trachea. Distal cuff seals off whichever anatomical structure it's entered. In the esophagus, if the long tube is in the esophagus, ventilation will be provided through the short tube. If it's in the trachea, if the long tube is in the trachea, ventilation will be provided through the long tube. Short tube designed to remain in the pharynx. Cuff seals oropharynx. If long tube is placed in the esophagus, ventilation will be provided through the short tube. Ventilation enters distal pharynx below the inflated oropharyngeal cuff. Or esophagus sealed by the distal cuff of the long tube. Ventilation enters obstructed trachea. Ventilation is provided via BVM. And this is similar to the combitube. This is a blind stick one-shot device. Whenever these tubes are ventilated, this area here is what ventilates. Whichever tube you get rise and fall of the chest with is the one that you would ventilate through. There are also advantages and disadvantages of this airway. On the advantages side, it can function in the trachea or the esophageal position. No face mask to seal. It's a blind technique. No specialized equipment. Can be used in trauma patients. Protects the trachea from upper airway bleeding and secretions. From this one right here. Disadvantages: does not isolate the trachea. PTL can become dislodged. Intubation around the PTL is very difficult. Not enough area at all to see the glottic opening. Cannot be used in a conscious patient or those with a gag reflex. Cannot be used in pediatric patients, and can only be passed orally. Laryngeal mask airway, or the LMA. Blind insertion technique. Tubed cap with an inflatable rubber collar designed to cover the supraglottic airway. And this airway is exactly what it says it is. It's a laryngeal mask airway. It masks the laryngeal or the glottic opening. Ventilation is provided via a BVM. Cannot be used in patients with a gag reflex and does not isolate the trachea. No protection from aspiration. And as this is inserted into there, this mask device here, which is this, masks the glottic opening, and then as it is ventilated through here, air would go into the glottic opening area. Laryngeal mask airway. There's another type of LMA called the intubating LMA, or the LMA FASTRACH, initially used as a standard LMA to ventilate. An added advantage of allowing passage of up to an 8 millimeter cuff endotracheal tube through the device into the trachea. Epiglottic elevating bar lifts epiglottis, allowing for unobstructed path of the endotracheal tube. Rigid handle facilitates one-handed use, allows for repositioning of the device in the pharynx if necessary. Blind insertion technique, minimal training and no special equipment required, and this is in an adult only. And this is the device. When inserted and blown up, this is the LMA part that we're looking at here. Blind insertion, move to depth, cuff inflated, which is this here. Once that occurs, ET tube depth markers right here. Insert the ET tube. This kind of hooks up. Stabilizing rod is removed. Once the ET tube is confirmed, the LMA can be deflated and then removed. And then you have a secure endotracheal tube. COBRA parapharyngeal airway 102. A single-use disposable supraglottic airway similar to the LMA. COBRA head of the device manipulates the anatomy and lifts the epiglottis, holds the surrounding soft tissue out of the way. Ventilations via BVM through fenestrations on the distal end or holes through the distal end, or the head of this. Available in adult and pediatric sizes. And this is it right here. Surgical airways. Used after failed orotracheal intubation attempts. And indications on this: inability to ventilate or intubate a patient by oral or nasal routes. Contraindications: ability to ventilate or intubate the patient by oral or nasal routes. Inability to identify anatomical structures. Any morphology or pathology that would prevent successful procedure. And final note on this: if ventilations can be accomplished via a BVM and a BLS adjunct, do not cut or provide a surgical airway. Needle cricothyrotomy 102. Temporary surgical airway. Uses a bridge until a surgical cricothyrotomy or other definitive airway can be secured. Uses transtracheal needle. Transtracheal via cricothyroid membrane. A large bore needle should be used, 14 gauge or larger. The bigger the hole, the better the airway you're going to provide. Find your cricothyroid membrane. Thyroid cartilage, first cricoid ring, cricothyroid membrane. Be sure you have adequate placement. Place a syringe on a needle that you're inserting. As you introduce the needle into the cricothyroid membrane, pull back on the bar just a little bit. You should get a nice amount of air once you've entered the tracheal opening. Once you're there and you have confirmed placement, thread the catheter on the top, or thread the catheter all the way to the hub, and this will introduce it into the tracheal opening. Let's go back one. Once you've got it into there, you'll need the transtracheal jet insufflator. It provides a very high power, pressurized burst of oxygen. Remember, whenever you have this in there, the airway is small. It's this 14 gauge. As you're inflating it, remember to double, if not triple, the amount of expiratory time. Needle cric versus a surgical cric. A needle cric is easier to initiate. There's fewer complications. However, the transtracheal jet insufflator is needed to provide adequate ventilations. BVM is inadequate for providing adequate ventilation. Potential complications of a needle cric, and that would be barotrauma, hemorrhaging, subcutaneous emphysema, especially if the air is escaping around the insertion site. And you can have this in multiple locations, not only in the pleural cavity, in the clavicular areas, but also in the mediastinum. Hypoventilation, misplaced catheter, improper equipment, incorrect use of the jet insufflator. Surgical cric, hyperextend the supine patient's head. Neutral position if cervical spine injury is suspected. Open cricothyrotomy. Airway is opened at the cricothyroid membrane. Endotracheal or tracheostomy tube is placed in the trachea. Can be performed rapidly and does not manipulate the cervical spine. This is going to be a surgical cric. Complications: tube placement in false passage, laryngeal tumor, thyroid trauma, hemorrhage, laryngeal nerve damage, subcutaneous emphysema, vocal cord damage. Contraindications on this or surgical cric are going to be children under 12 years of age. Cricothyroid membrane is difficult to identify in these individuals. As far as the procedure, identify the cricothyroid membrane, clean the area with aseptic solution, stabilize the larynx between your thumb and your index finger of your non-dominant hand. With a scalpel in your dominant hand, make a 1 to 2 centimeter vertical incision. This is going to be our first incision pattern. Chin is here. Identify the cricothyroid membrane and make a 1 centimeter horizontal incision through it. So once we identify the cricothyroid membrane, we'll make an incision like this. Insert curved hemostats through the incision membrane into the trachea and spread it open. Insert a cuffed endotracheal tube or tracheostomy tube head into the trachea. Inflate the cuff and ventilate, confirm tube placement, and secure the tube. We also have a video of this being performed on a mannequin in the skills section. So we find our cricothyroid membrane. We make a vertical incision. We identify the cricothyroid membrane again. We make a horizontal incision, very small, in that area. Paracurved hemostats. We open up that area and insert the tube as a guide wire into there and confirm placement and ventilate our patient. That is going to be the end of part 3. If you have any questions concerning this, feel free to contact me, r.smith@redlandcc.edu or smithr@imsa.net. Thank you.